Thank you all for joining us in support of our military and veteran communities. I'm Dr. Jenny D'Olympia, the Director of the Military and Veteran Psychology and Trained Vets to Treat Vets program here at William James College. I am also a veteran and the spouse of a military member. And you guys are welcome to introduce yourselves in the chat if you wish to do so. But before we begin, I'd like to apologize and take full responsibility for any inconvenience for our scheduling complication. We have put in additional features to make sure that we avoid that kind of difficulty in the future. And we remain committed to delivering you quality didactics related to providing mental health services to our military, veterans, and their community and their community and their families. Today's discussion is brought to you by a partnership between William James College and the Massachusetts Veterans Services. If you have any questions along the way, please add them to the chat and we will do our best to address them throughout the discussion. Today's program and speaker will be introduced by one of our rising fourth-year students in our clinical psychology doctoral program. Jane Parr has an MBA and a Master of Arts in Psychology. She earned her Bachelor of Science in Arabic at the United States Naval Academy and received a Master of Business Administration from DeVry University. Currently, she is in her first year of her APA internship at Rhode Island College. Previously, she served honorably in the United States Marine Corps, ending her service in 2017 at the rank of captain. Her professional interests include continuing the growth of cultural intelligence in the psychology field, and working with individuals impacted by substance use disorder. Jane?
Thank you very much. So I'm introducing Dr. Celio. He'll be presenting today. Dr. Mark Celio is a clinical psychologist in the Collaborative Addiction and Recovery Services Clinic at the Providence VA Medical Center in Rhode Island. He is also an assistant professor at research in the Center for Alcohol and Addiction Studies in Brown University School of Public Health. Welcome, Dr. Celio. I'm excited to hear the presentation that you have.
Thank you very much, Jane, and thank you to all in attendance. It's a pleasure to join you virtually. I'm going to share my screen and see if I can get this to work. So just hold on one moment. And there we go. So can folks see my slideshow?
Yes, we can.
Wonderful. All right. I am going to try to zip through because I probably have way too many slides, and I definitely want to have opportunity for discussion and questions. So please, use the chat feature. I know that I'm very happy that we have several veterans with us in attendance. They may be able to answer your questions better than I, but I'm going to focus on the presentation and answer any questions that come up perhaps at the end. So as Jane mentioned, I work in the Collaborative Addiction Recovery Services Clinic at the Providence VA, interdisciplinary team of psychiatrists, psychologists, social workers, nurses. We have a clinical pharmacist, which is an awesome feature, and we provide full range of services in support of addiction recovery, which includes alcohol, other substance use, and also behavioral addiction like gambling or, impulse shopping, you name it. So my first objective for today is to identify several factors that influence substance use, specifically, substance use and treatment engagement, specifically among veterans. So data from the 2019 National Survey on Drug Use and Health, I couldn't find any newer version of the National Survey on Drug Use and Health. I imagine any newer version of that survey, the data is going to kind of be off the charts because that would cover sort of like pandemic life. But the data from the 2019 survey demonstrates that about 15% of our veterans have some form of mental illness. About 6% of our veterans have some form of substance use disorder. Right? About 27% of them struggle with illicit drugs, about 81% struggle with alcohol use, and about a little less than 8% struggle with both illicit drug and alcohol use. And then you have this group in between where about 2.3% have both a substance use disorder and mental illness. Now, all these rates are lower than the rates observed among the general population except one. And I have a question for the audience. What is the one data point on this slide that is higher among veterans than the general adult population? You have to unmute yourself and say it because I can't see the chat. Courageous souls. What do you think?
Alcohol.
Alcohol. Spot on, right? So yes, I don't know if it comes as a surprise or not. It really shouldn't come as a surprise, I don't think. But our military women and men that serve are screened extensively for physical and mental health prior to their time in the military. So you have a healthy population of service women and men. So, the overall rates of mental illness and substance use disorder are understandably lower than the general population. But alcohol use is higher, and specifically alcohol use is higher among the youngest of our veterans in the 18 to 25 year age range. After that, outside 26 and older, it actually kind of gets more comparable with the general population statistics that we see. The landscape of other substance use among veterans looks like this. Mostly cannabis use, although that's significantly lower than the U.S. population. Some misuse of prescription drugs that are not prescribed to these individuals, or maybe overuse of drugs that are prescribed to these individuals, again, lower than the overall U.S. population, and nothing really remarkable beyond that. Treatment utilization, might come across as sort of like a, shocking number, in that 85% of the individuals who do meet criteria for a substance use disorder are not engaged with treatment. But even that is significantly lower than the U.S. population, the U.S. population being 90%. So, it's still a concern, but, again, kind of this idea that we're doing just a little bit better than the general U.S. population. But, why are treatment utilization rates low among veterans? So I guess maybe, I don't know, the shortest possible answer is that the Department of Defense medical records are not exactly confidential, in the sense that the Department of Defense can't access medical records if they need to access medical records in the context of a review of a particular individual. So just this knowledge of this kind of creates an understanding that, I could be negatively impacted by anything that is in my medical record. So consequently, a significant portion of our military population believes that seeking help would negatively affect their military career. So that and zero tolerance policies around substance use could result in a dishonorable discharge, at which point individuals no longer qualify for VA healthcare once separated from the military. So even if it isn't a matter of their military career, it may be a matter of, like what type of access do they have to treatment after their military career. So some significant considerations that might influence why folks don't seek treatment. But the military culture itself also serves as a barrier to treatment utilization. By necessity, military service hones a specific set of values and characteristics. These values and characteristics are critical in situations that our military service members find themselves in, right? So, they are admirable qualities indeed, necessary qualities, right? Putting mission first, emphasizing others over oneself, right? These concepts are unfortunately kind of incompatible with prioritizing self-care, right? So, we can maybe kind of get into more of that later, but, it's just sort of this like overarching kind of like culture of sorts that like, well, look, I have a more important focus, and that's the collective above and beyond myself. But this sort of like, hardened mindset is really incompatible with the diverse range of emotions that service members and their families experience before, during, and after deployment, and even outside of the context of deployment. It's a rich and diverse emotional experience, service in the military. So in many ways, this concept of a warrior ethos is actually more acceptable, maybe a more comfortable space, especially when it's sort of like, it's like this universal experience that all service members may be able to relate to. One can kind of almost like ground in the sense of purpose, really depend on that as a source of kind of like motivation, strength, and this to every degree that it serves as an advantage, it does in ways kind of like not exactly line up with maybe some of the more individual experiences, some of the more emotional aspects that don't neatly fit into military, the concept of military experience. And, it's not the only thing that kind of addresses this. There's other, like ways that people cope, but this is certainly where alcohol presents itself as a viable coping strategy, right? Alcohol is accessible in the context of most military service. It's broadly accepted. It almost has normative qualities. I talk about social norms in other contexts, certainly the social norms around drinking in the military. And it's generally effective, I use that word lightly, but it is genuinely effective at providing acute relief in the form of what I hear described as emotional numbing. I just wanted to not feel what I was feeling at that particular moment, and alcohol served that function, right? We're focusing specifically on alcohol right now because, remember, zero tolerance on substance use doesn't have that same level of acceptability, to some degree, I imagine, access, but still, alcohol use really seems to be a go-to. But of course, the problem is that reliance on alcohol or other drug use to manage mental health issues tend to just exacerbate the issues themselves. So I know that was kind of like fast and light, but moving on to exploring the connection between substance use and PTSD as well as suicidality. The incidence of PTSD among veterans is very high, right? It's almost a universal feature of military service to be exposed to potentially traumatic events, with 87% of people who serve having some exposure to a traumatic or potentially traumatic event. The average number of potentially traumatic events experienced by veterans or military service women and men is over 3. And this kind of makes it understandable why the rate or the incidence that we see of PTSD among veterans compared to the general population is about double. And elevated PTSD is not exclusively a product of deployment. Deployment is certainly a factor, and I think the highest incidence of PTSD is observed among male veterans who have been deployed, but it's also alarmingly high among veterans, male and female, who have not been deployed. Slightly higher among female veterans who have not been deployed than those who have been deployed. So, this is, it's not just an issue of combat or other forms of deployment. It's an issue of just the increased exposure in training, service, and and perhaps even like the heightened sense of stress that I was alluding to earlier that comes from maybe like a detachment from one's support network, the complicated set of emotions that goes along with that, and on top of this, a lot of the other things that people are exposed to. So the co-occurrence of PTSD among individuals with alcohol and other substance use disorders is like staggering data. And I know this is actually dated data in that it's coming from 2011. It was really like the best chart that I could find to kind of depict this point. But back in 2011, we saw that among individuals with an alcohol use disorder, veterans with an alcohol use disorder. And to clarify specifically, this is veterans from the wars in Iraq and Afghanistan. Alcohol use disorder and substance use disorder among individuals with either, about 2/3 or just under 2/3 also had co-occurring PTSD. Depression's also higher, but we're focusing on PTSD here. And for individuals who had both alcohol use disorder and substance use disorder, PTSD is, over 75%. So clearly there's a strong connection between post-traumatic stress and alcohol use. And this is where we get back to the concept of alcohol and other substance use kind of as this like self-medication mechanism, right? What this model depicts is a cycle in which post-traumatic stress, and I would actually revise it to say post-traumatic stress in the kind of like the top bubble, may very well prompt individuals to use alcohol and other drugs as a form of kind of like acute and immediate relief in a context where, again, where we have other options. There are other tools that are made available, but seeking those tools may not feel or even be as appropriate to the individual as something such as alcohol that does provide that short-term anxiolytic relief. But then as a product of kind of like negative reinforcement, that relief that one experiences does in turn promote more escalating substance use to continue to cope with either new situations or the same situation, ultimately, kind of, creating that opportunity, almost cultivating the development of a substance use disorder. And then it does become a cycle because, interestingly, substance use disorders may actually exacerbate the initial post-traumatic stress into post-traumatic stress disorder, right? In the sense that, it maybe interrupts other sort of ways that an individual might recover and kind of allows the post-traumatic stress to then sort of amplify itself. But also substance use does expose individuals to more potential for traumatic events to occur. It's not something I'm going to delve into too much, but, individuals that are acutely intoxicated can and do find themselves in situations that are dangerous. So you do find more exposure to traumatic events, thus kind of compounding and creating this like complex post-traumatic stress disorder. So it becomes sort of like a vicious cycle of sorts. Like switching focus to suicide, of course, suicide is another major concern among military and veteran populations. I guess, it was already pretty high, but, I guess after like 2006, saw a pretty sharp increase that's been kind of like plateaued since then, in that, there's a high incidence of suicide among military and veterans. The comparison to non-veteran populations kind of amplifies the concern. So, compared to the general population, females, the suicide rate among female veterans is more than double. The suicide rate is highest among younger male veterans, but the actual count is highest among older male veterans. So really, like, the takeaway from this is that all veterans are a priority when considering suicide prevention. Right? We don't really focus in on any one particular demographic. We certainly have reasons to believe some demographics are more at risk than others, but really, just as a whole population, suicide prevention is a key part of preventative treatment, really. But perhaps the characteristic to pay the most attention to is individuals with a substance use disorder. I mean, I'm sure there are other characteristics that put individuals at higher risk, but this is a significant one. This chart shows that the incidence rate of suicide is double among male veterans with a substance use disorder compared to all male veterans, and 5 times among female veterans with a substance use disorder relative to overall female veteran population. So, again, kind of clearly highlighting that, like, substance use is definitely sort of like playing a very concerning role in suicide, much like it plays a concerning role in the development and sustaining of post-traumatic stress disorder. What this chart shows is that if you do break it down by specific substances, it suggests that sedative use disorder is particularly concerning, as is opiate use disorder among females. I think in part because these substances are themselves lethal means, right? So individuals can easily overdose on sedatives. Individuals can easily overdose either intentionally or unintentionally on opiate use disorder, on opiates, sorry. But alcohol and other substance use, while it is kind of like a unique risk factor for suicide, due in large part both because acute and chronic impairment in judgment and impulse control is kind of like a quality of alcohol or other substance use. I kind of wanted to take this opportunity, without going like too specific into it, to highlight that, alcohol and other substance use, especially when their purpose is coping, kind of erode at one's protective factors against suicide. So not only is alcohol and other substance use a unique risk factor for important reasons, but it also undermines and potentially removes the availability of key protective factors. So things like diminished problem solving, fractured support systems, being in unsafe environments, increased isolation. These can all be direct byproducts of prolonged substance use disorder. So, I just wanted to make that point that it's not necessarily kind of like causal, but it is, I think, a very significant factor to consider, that each of these protective factors does ultimately relate to, are these being utilized as a coping mechanism, or are, something else maybe being utilized as a coping mechanism that unfortunately doubles back and kind of makes these even harder to use. I guess the good news hidden here within some bad news, again, kind of, I don't want to say like dated data, but, like a good infographic nonetheless, is that engagement with VA does appear to prevent suicide. In part, I believe, by bolstering veterans' availability of and utilization of protective factors. So the overall message of this infographic is that while suicide rates have generally increased from 2001 to 2014, probably kind of continued on from there, they increased far less and even decreased among females for those who engage with VA services, right? So, I mean, females, it's like a remarkable comparison there to see that, for female veterans with no recent use of VA services, from 2001 to 2014, 82% increase in the rate of suicide. And by contrast, those who have recently utilized VA services, the rate actually decreased over that same period of time. So, I guess it's a little plug for utilizing VA services, which I guess kind of does become maybe the challenge, right? So the last part of my talk, maybe kind of like it's about half though, focuses on discussing strategies and evidence-based practices used within VA to treat veterans struggling with substance use disorders. I'm doing better on time, I think, because I'm trying to like hustle it up. But, maybe at this point, it would actually be a good time to stop and check in if we have any questions or if we have any points that we'd like to discuss about the presentation so far.
Dr. Celio, I kind of wanted to jump in after the last slide, just to comment kind of on like the veterans side of things on like the access to VA.
Please.
Yeah, so like for people who don't know, like in getting out of the military, like people can apply for VA services. And there's a lot of stigma that can play a role in if they choose to apply or not apply. And that depends on like what unit they're in, the support they have from their leadership and all those kinds of things. But once they get out, applying, if they haven't applied within, can make it really, really difficult. And so that's just kind of like that transition. Like it might depend on access before they even get out and kind of know if they need services. Kind of the other side of that is we're focusing on the VA because Dr. Celio works with the VA and that they're kind of like the leading realm of treatment. But as you saw some of the numbers, like for females, like treatment has gone down. There are times when service members really don't want service through military affiliated places and maybe don't want service from people who've even experienced military experiences. So if you who are participating don't have that background, that shouldn't limit, and that should actually like bolster you to know that like you can still be very supportive of veterans. It just gives them like a different perspective and a different realm than what they've been experienced a lot of their trauma in, whether it be combat wise or not. So getting the treatment outside of the VA is also really important. We don't have, this is kind of more like personal experience, but I'm kind of throwing that out there because I think it's important to know. So yeah, thanks, Dr. Celio. I just wanted to comment on that last VA slide.
No problem. I fully acknowledge that, the knowledge and experience that the veterans that are present with us today have far surpasses any data point or slide that I have. I mean, I think the one thing that I have is, the experience of working with those who do access services and, seeing that, like there are like a broad range of services that are available. I think that it's just, facilitating that that connection can be really tough. And sometimes you say, all right, well, look, is it a matter of facilitating the connection to VA or just a matter of facilitating connection to treatment? I think, I would say, to me, I'd rather see folks in treatment if it's in a community. Awesome. But sometimes I think maybe like the main takeaway of the earlier part is that, that there can be almost this, this mindset that's cultivated that, I don't need treatment because, I have, it almost conflicts with my values. Yeah. Other thoughts?
I noticed Darcy Schultz in the chat brought up if there are any stats on LGBTQ plus community. And I know there are stats. I don't believe we have them in the presentation. But right. It kind of goes along with like maybe the decrease of treatment vets. It takes a while for like the big cog of government to make adjustments to more modern ways of treatment. And so like just recently, I think it was maybe like 6 years ago, the VA in Boston put in like a women's clinic. So they're just putting those things in. So it takes time. but we don't have that info in the presentation, but I would say
Yeah.
it is out there. I don't know, Dr.
So,
Steele.
so I had a slide, and from the SAMHSA National Survey on Substance Use and Mental Health, I had a slide that's focused specifically on LGB. It was actually just LGB. I guess they maybe didn't have trans individuals in their data set, or perhaps not enough trans individuals in their data set. So it was just LGB, the way that they defined their data set. But the data certainly wasn't parsed down to LGB veterans. But the takeaway message from that, and I kind of had it in my presentation, I was like, and I don't know how I'm going to use this or not, was that just staggeringly high rates of substance use disorder, mental health issues, and co-occurring substance use disorder and mental health issues. So I think to extrapolate from that and say our LGBT service members, we could just assume that they're struggling with both the issues that apply to their military service and their identity. So beyond that, I kind of got pretty concerned about how much time I have in the presentation. So I'm glad that we can discuss it. And I think that maybe when we get back to the end, if there's specific questions, we could talk about it as a group. Any other questions for now? Because I'm going to re-engage with the presentation. All right, so I would like to discuss, so there we go. So can we see my slides again?
Yes, we can.
Strategies and evidence-based practices used within VA to treat veterans struggling with substance use disorders. I initially, and when talking about this presentation with Jane, really thought about including a section on the programs that are intended to facilitate access and sort of like transition into services, facilitating services at VA. But in kind of exploring it, I realized it's really beyond the scope of this presentation, because it kind of delves into so much of, what's, I guess, being done, and ultimately wouldn't really have left a lot of time for talking specifically about evidence-based treatments for substance use disorder. But I just wanted to highlight literally that the post-deployment and readjustment program is one of the many mental health services that we provide, that we have at the Providence VA, and it's a federal initiative that's at many, if not all, VAs to try to work with veterans who are initially engaging with the VA system, whether it's post-deployment or whether it's just simply, when they're coming into contact with us, and what services that they provide through the program can kind of like help and are designed to facilitate that connection and awareness and utilization. As far as accessing alcohol and substance use treatment, it often looks something like this, right? Where even folks who know, maybe understand, and have considered what options they have available for treatment and what they'd like to do, often find to some degree that they're either being pushed in by others, either quite literally or just sort of feeling like, like I'm not just doing this for me. In fact, I'm doing this more so for others. What we know broadly in addiction treatment is that it's not a good recipe for success, because folks tend to resist when they're being sort of told or forced into doing anything, which is why the VA has rolled out training in motivational enhancement therapy as an evidence-based technique for working with veterans with substance use disorders. Rolled out basically is like a VA term, or maybe a military term, or kind of to say like this is a training program that is made available for providers in the VA to learn and utilize and have like a full range of support. So this is one that is, like very widespread and accessible, and I highly recommend it. So I think motivational interview is something I've been doing far longer than my involvement in VA. I think of it as more of a style or approach to therapy as opposed to a treatment itself. I mean, it is grounded in 5 principles intended to cultivate the sense of intrinsic motivation, one's own motivation, and a sense of collaboration in the working relationship, as opposed to maybe the old style of, I'm the expert, you're the patient, you should do what I say. Beyond that, it also fosters opportunities for the therapist, who is an expert in what they do, to provide prescriptive advice that will be better received once one has kind of established this like mutual and collaborative relationship. So it's not all about client-centered. It's also about kind of facilitating opportunities for expert advice to be received and acted upon. So these. I'm not going to really delve into the principles. I'll talk a little bit more about the techniques. They're like the basic recipe for kind of like good therapeutic interactions, right? They're client-centered and intended to reinforce a dialogue about change, and also to reinforce change behavior from the client's perspective. So, what we want to do is we want to use open-ended questions as much as possible to allow the client or patient, veteran in this case, more time to talk about their experience, their thoughts, their feelings, their ideas, as opposed to doing a lot of the talking ourselves, which sometimes is kind of like a quality of therapy, especially a more like didactic, prescriptive therapy. We want to affirm always and support, the idea and the experience that people have of, both ambivalence, right? Because ambivalence is a real thing. Ambivalence is a human characteristic that's pretty much universal. So we want to acknowledge and affirm that, hey, ambivalence is understandable, but also affirming and really supporting any concept that, I might actually benefit from making some changes regarding my substance use. Always kind of, using more of a reflective style than a prescriptive style where, we're focusing on how can we kind of present back to our patients what we hear them saying about why a change is important, or a change that they have in mind, or the outcome of a change that they made, so that, we're not just sort of saying see, I told you. It's more like, well, it sounds like that experience was really productive for you. So it really kind of puts them in control to some degree of the choices and outcomes that they make in terms of therapeutic progress, right? And summarizing in a kind of like a strategic way, always kind of like using that opportunity to say all right, so, what I hear you saying is that, X, Y, and Z as much as possible. Because again, I think that it communicates to individuals that they're being heard, that they're being respected, and that their contribution is actually maybe like the most important contribution to the work that you're doing together. All right, so moving forward, the motivational enhancement sets the stage for other evidence-based therapies. The primary treatment rolled out by VA is called cognitive behavioral therapy for substance use disorders among veterans, CBT-SUD. The CBT-SUD is what I would call kind of like a semi-manualized therapy. All of the components are there, but with more of like a flexibility in how to apply them. So it's not like a session by session blueprint or map to how we do therapy, but it's kind of like, well, like within this phase, this is kind of like the sequence that you can move through in the time frame that it takes. The initial phase being about rapport building, enhancing motivation, orienting to the model, to the cognitive behavioral model, and also kind of other aspects of treatment planning, like whether or not the individual wants to include significant others or supportive others that could maybe enhance the treatment plan. The middle phase is, I think, what most of us think of as cognitive behavioral therapy. For those who are familiar with cognitive behavioral therapy, the same type of strategies that are applied to depression, anxiety, other mental health targets, packaged into a protocol that focuses on addiction and related behaviors and problems, always with the focus on motivational enhancement, collaboration, autonomy, and I guess this kind of like pull-out procedures so as to avoid confusion is kind of more like, when, like knowing when you may need to discontinue therapy for a different course of therapy. I'm not going to get too much into that, but if folks have questions, the latter phases are more focused on maintenance and ultimately termination, but they're not reflected in this slide. Functional analysis is really like the key tool employed to initially understand the relationship between triggers and responses, with emphasis on the function that the response ultimately serves. I guess this is the more behavioral component of the intervention. But this is the foundation for determining other substance-free alternatives that could serve the same or similar functions in each triggering situation. Right? Might be getting the sense that this isn't like veteran specific, but this is evidence-based strategies for treating substance use disorders, and it works with veterans and non-veteran populations alike. Urges or cravings for substance use are explored using the full potential of the CBT model, really dissecting experiences into thoughts, physical sensations, kind of these beliefs that individuals have about the particular substance or experience of the moment, what they're feeling, what they're doing. Urges, I think, ultimately become the focus of addiction treatment because it's in those moments that we need to have a strategy. And I think understanding and raising awareness to, and really kind of, just having like that full, rich kind of sense of what one's personal experience is with urges is a big focus. Sometimes people misinterpret urges. Sometimes people misinterpret other experiences as urges, and it kind of gets complicated. But this is a phase of the CBT protocol that really kind of hones in on, what are the moments that we're really working, right? And then, of course, kind of using like other core CBT strategies to then strategize for those moments, but then also monitor, like when those moments are occurring and what we're doing in those moments, so as to either kind of validate the plan that we have in place, or to come up with a new plan as we encounter situations where the original plan maybe didn't work. So, the assumption being that, like nothing is kind of like perfectly implemented and that's just success from there. But the idea that this is a learning process, trial and error. So monitoring situations where individuals experience urges, the intensity of that urge, and ultimately what was done, along with some other data points. I would want to know how long did the urge last, and some other things as well. But this is the process that also serves as a measure of treatment outcome, because the understanding from research is that as individuals experience urges and don't respond with substance use, the intensity, duration, and frequency of those urges will dissipate over the course of time, right? So any particular urge itself will peak and dissipate over a relatively short period of time. But over the course of repeated experiences with that, the urge intensity isn't as high, the urge frequency isn't as often, and even how long they last is ultimately described as like say more of a fleeting thought after an extended period of abstinence. Refusal skills is another part of what we do, kind of maybe again on the more behavioral side, but certainly factoring in emotional experience as well, that we work a lot with people around what they will say and do when individuals offer them either a drink or an opportunity to go someplace where they're concerned that they might drink. Right? So a big part of the CBT SUD program is around identifying and practicing the things that people will the communication skills that people will use to navigate situations that they're in, or possibly prevent situations that they don't want to be in. This is kind of like a fun and effective kind of component of the treatment protocol. And then there are elective components as well. Veteran and therapist may choose to incorporate one or more of these based on the individual patient's needs. But I thought it was really interesting that each of these electives also enhances protective factors against suicide. I'm not 100% sure that was made clear in the training for this, but I don't think it's a coincidence. But when you get back to this idea about how alcohol and other substance use can maybe erode at some of these particular skills, let's call them, for the CBT SUD protocol to then go back and say like, all right, now let's kind of enhance those again. It's definitely fulfilling or kind of supporting a recovery goal, but it's also going to support, a suicide prevention goal as well, even for individuals that maybe aren't high risk for suicide. So the last treatment approach, and I think we're good on time, I can do this pretty quick. Last treatment approach I wanted to discuss that I think is pretty unique to VA, at least in terms of the ability to implement and sustain an evidence-based intervention that is particularly hard to implement and sustain, is contingency management. So VA has a well-established network of contingency management programs. 18 VAs conduct abstinence contingency management to support abstinence from cocaine and cannabis, and 14 VAs conduct adherence CM to support ongoing engagement in long-acting medication protocols, specifically Vivitrol, which is like a once-a-month injection for alcohol use disorder. It helps reduce urges for alcohol use, and Sublocade for opioid use disorder, which again is a once-a-month injection that replaces daily Suboxone medication regimen. And what we're seeing here is the fishbowl, right, which includes 500 slips, half of which just say good job. The next significant portion say $1, about 40 of them say $20, and one in there says $100, right? The basic premise of this is that individuals within this protocol incrementally earn more draws from the fishbowl for negative screens or for their monthly Vivitrol or Sublocade injections, but a positive screen for cocaine or cannabis, or a missed injection at a given like time point, results in 0 draws for that particular time point and a reset to 1 draw at the next contingent event. So, with regard to like the abstinence CM, which we do at Providence, but it's kind of sidetracked for right now because of the pandemic, but we're going to get back to it as soon as possible. Once an individual is up to 8 draws per visit, they're pulling out prizes, right? They're definitely pulling out prizes, and oftentimes it's, like amounts to a significant amount of monetary reinforcement. I think the VA can do this because we have our own currency, these Patriot bucks that they can use in the VA store or the cafeteria or things of that nature. And you can get anything that you might be interested in the VA store. It's a pretty versatile store. But again, I think the idea here is that, once someone is up to that 8 draws and then they get to run that out for an extended period of time, there really is like a tangible loss when one has to kind of reset back to the beginning. So, folks are highly motivated to maintain engagement in this type of program. And, some might say it's a controversial program to pay for abstinence or adherence, but clinically, I would take this type of support anytime I can get it, because not only, does the data suggest that you see much higher rates, this chart focusing on cocaine abstinence, much higher rates of abstinence for that 8-week window that we're working with individuals, because the abstinence CM is twice a week for 8 weeks. It also is an opportunity to see that person all those times. They are in there not just for CM. They're participating in groups. They're participating in individual therapy. They're utilizing other services. They're also having a little bit of fun in the context of this program. There's always a secondary benefit to that. But I think that the nice thing that this provides is, that extra level of engagement with the healthcare system that, comes at a very, I guess maybe one might say, insignificant price, given sort of like the cost of the program itself. So while it may be like some might feel different about paying someone to engage in treatment, it can actually be a really beneficial tool in the toolbox. So in summary, military service certainly cultivates admirable qualities for sure. And the values are, again, highly respectable and completely necessary. But sometimes those characteristics may cause individuals to feel conflicted when it comes to seeking self-care, right? Alcohol and other drug use may present as a form of self-medication that actually seems a little bit more acceptable. But prolonged or problematic alcohol use can exacerbate other problems such as post-traumatic stress and suicidality. And as a very broad statement, the VA does provide a broad range of services for addiction recovery, post-traumatic stress, suicide prevention, really anything else, mental health, or even sort of like this whole health concept. But yeah, there are certainly factors that still interfere despite the fact that these are available. Maybe we can talk about those now. So yeah, that's what I got. Questions, comments, thoughts from any and all present?
I wanted to
Could you
comment.
tell me?
So it sounds like 2 folks wanted to comment. Maybe we'll go with, and now both of them have disappeared?
Darcy Schultz, would you like to comment? I saw you on mute first.
Yeah, I didn't want to interrupt the person that was on their phone. I don't know who that was. I noticed that and then I muted right away. But I am like kind of overwhelmed by the statistics. And thanks for like responding to my questions. I'm really worried about like the rate of suicide and, what's been in the news recently too. And so, I mean, this really kind of highlights that it's been addressed. It came out in the news after the wave had passed. But that was what my question about the LGBTQ was about too, because of the high rates of suicide completion in trans populations. And so I just wanted to comment that it's pretty overwhelming, the statistics. Like it's, yeah. I have military family members too, and I had no idea. So
yeah. Yeah, so one of the challenges that I had in preparing this talk is that I can't speak as sort of I can't speak well to the more sort of like Department of Defense side of how they're approaching these same issues, right? But on the VA side, we have suicide prevention, screening at almost all levels of care engagement, right? So if you present for any treatment, whether it's mental health or not, you are going to engage with an individual around some of the kind of like preventative screens, suicide being one that we do, I think, more often than others, just to cast a wide net and possibly catch individuals that we could really benefit from some enhanced service. We're talking a lot in our staff meetings about this like reach vet program where, there's like this, kind of like big data analysis sort of process going on behind the scenes that just helps to identify individuals that providers may want to have a dialogue with about whether or not their care experience can be enhanced through other services, because we're picking up on, or the big data machine is picking up on risk factors. But again, there's that type of thing that's going on. There's the person-to-person screening that's going on. The problem is folks have to engage with VA to really engage with that type of preventative screening. I'm concerned about the folks who aren't engaging with VA because I don't know to what degree the same level of like focused screening and prevention is taking place in community settings.
I know we're pretty much out of time, but did the person on the phone
Yeah. Oh, the person on the phone, we're free to go with your question if you'd like.
Okay, thank you. This is a two-part question. Is there a way to find out where these women's centers are in the VA network? That's A. And B is, how open is the VA to alternative treatment methods for substance abuse, depression, and suicidality?
Yeah. So the first part, maybe other folks, especially those who organize this, might actually be better at identifying, like what services are and how to identify services. I think the question was specifically for women.
Yeah, Jenny threw a link in the chat, and so that information is out there with that, but then you can cover the second if you'd like.
Okay. Yeah, the second is actually really interesting. So, we have a new initiative and a great clinic that I send a lot of folks to called, it used to be the Integrated Health and Wellness, but now it's called Whole Health. And what Whole Health provides is a number of different holistic treatment alternatives, and many of which actually do have an evidence base for treatment for addiction, something like acupuncture. I know when I was, meeting with folks and talking about acupuncture at the West Haven VA in Connecticut, they very much are using acupuncture as a treatment approach for addiction. Right. But, acupuncture may also be used for pain management. Pain ultimately relates back to, I had some slides on pain and addiction. We want to talk about another reason why individuals may find themselves in a situation with a substance use disorder. Pain is a big one, but I unfortunately had to cut it out in the interest of time. But the Whole Health Clinic does offer a lot of alternative strategies. If we're talking about alternative strategies more along the lines of like say, like medical cannabis or, like ketamine treatment and things like that. The VA is not there yet. But I will say that the VA has embraced medical cannabis sought in the community. So there's no longer, or at least a greatly reduced stigma among veterans who are saying like, look, I use medical cannabis and don't have the same degree of concern now that medical cannabis use would actually impact their access to other services through VA like it would have 8 years ago or something to that effect.
Go for it, Michelle Waldman.
Hi, I'm sorry. It was wonderful. I really wish I could stay, but I have another meeting. What do we do about the CEU thing?
I will be emailing you a feedback survey, and once you fill that out, you'll receive an automated email with a link to your credit certificate.
Thank you. Thank you. I really appreciated this. It was so right on. It was great. Thank you.
And for those who ask questions over the chat that we might not have gotten to, I know Jeffrey asked a question about things. In that email, there will be Dr. Celio's email as well. So if you'd like to ask questions and reach out to him, that will be included as well. So
I certainly have a moment for any other questions if we want to field any of those right now. But yeah, or any other questions folks have. But I respect that people may have to leave for other meetings. So please do so if you must.
And I just want to thank everyone for joining us. For those of you who do have to leave, thanks again for your attention to the military and veteran community. It really is an honor to be a part of this process of sharing the information with you. And we hope you'll return to hear our next discussions next month on the third Friday of the month. We'll be talking about crisis leadership. So, and that will be delivered by a retired Army colonel. So thanks very much.
Oh, thanks very much. It was wonderful. I have to go.
yeah, okay.
Bye.
I'm just looking through the chat now to see if there's anything that
There was one from Jeffrey Arnold referring to the decrease in price and the lack of tax on alcohol on base and how that might have an effect on alcohol use.
Right. I mean, again, like that goes to this concept of access and conveys a certain degree of acceptability, right? So I'm sure that there are some contexts where maybe alcohol isn't accessible. I was thinking about this, and I'd have to ask some of my Navy veterans, but I don't think they're bringing alcohol on the submarine, right? But that said, I know that in many other situations on bases and like in like the field that alcohol is essentially made available, which conveys this is okay, right? So that when you're in a situation where you say like, hey, like going and talking to a mental health provider may not be okay, but alcohol is okay, right? And camaraderie is always okay. But even like the camaraderie and the alcohol sort of like overlapping pieces may kind of convey this idea like, all right, well, look, that's my coping strategy. My coping strategy is camaraderie and alcohol. Then again, not at inherently a problem, but perhaps the starting point of a problem, right? Lots of people use alcohol to cope in non-problematic ways. I mean, I'll acknowledge that. But sometimes when it becomes a primary coping strategy, or sometimes when it becomes a recurrent coping strategy, then it does kind of like grow, right? So I think that the main point there is, well, if that's what's made available, then it's gonna be utilized. And it's a great point that we're saying, all right, hey, cigarettes was the other thing. Not to throw out anecdote, but like my father, who served in the Army, went to basic training way back when he did, and they gave him like 2 cartons of cigarettes as like part of his sort of like, all the various, like what he was given, like clothes, boots, soap, cigarettes. He didn't even smoke, but he started smoking because he was given the cigarettes. So it's actually the case. I didn't get into tobacco use, but it's the case that a lot of people they initiate smoking in the military. So, the access is an important point, but, to that point, try taking it away. I mean, were they to say like, all right, well, now we're going to sort of like go back on that, I almost wonder, what type of response you'd have to that. So it's a tough point to wrap your head around.
It's like there's a question in the chat as well as
Yes.
somebody with their hand up there. The question in the chat, do you want to read it, Jane, or you want me to? I don't want to. Okay, got it. So the question was suggestions for resources to pass along to help educate the staff working in courts for a drug abuse veteran specialty court. I think we could email that, like all these links that we've shared in the chat, and if you have any additional.
So drug abuse veterans specialty court. And what was the question? I'm sorry, because I'm not seeing it.
Suggestions for resources to share with them to help the staff working in that court.
Right. So in my clinical role, I wouldn't say I'm like a point of contact, but I do work with a lot of veterans that are in the Rhode Island Veteran Treatment Court. And the entity at VA that's working most closely with them is the Veterans Justice Outreach Program. They are exceptionally well resourced in terms of sort of, like what is available both in the community and through VA. So what I would do is I would, direct any questions or maybe check out some of the web-based materials for the Veterans Justice Outreach, either locally or as a national initiative. And that should really, I think, be like a good starting point for any resources.
I shared that in the chat, the Veterans Justice Outreach link.
And then,
yeah, they're great. They're great. I love them.
And then we can transfer over to Helene Scarlett Golan if you have a question. You just muted yourself.
Hello, Helene. We can't hear you if you have a question.
Camaraderie and alcohol are so closely linked for so many young men, especially. Yeah. And I'm wondering if there are a lot of thought to ways to unlink them, like providing groups for camaraderie that are free of alcohol.
Right.
So a new way of connecting,
Right. So in my past life, as a graduate student, I studied social norms as like a risk factor for alcohol, other substance use, gambling, and the potential for sort of like normative feedback as an intervention, right? Mm-hmm. And I think that it certainly gets to, or at least is one option for how some might approach that type of discussion, right? Because the way that kind of grew over time is exactly the way you're describing it, like actually getting not focus groups together, but getting groups of individuals together and having a dialogue around perceived norms, actual norms, and some of the beliefs that people share, or some of the beliefs that people have that can sometimes be like misperceived, right? With that misperception being kind of like the driving force that sometimes makes it seem like, hey, you know, like everybody wants to do this, so I do too. I was just talking to one of my patients yesterday about this concept of like pluralistic ignorance, like going into this saying like, hey, I don't really want to do this thing, but I think everybody else does. So I'm going to do it anyways. And the frequent occurrence where multiple people or individuals that constitute a group may actually all feel that same way. So you have, you know, 4 or 5 people in a group all saying, I don't really want to do this, but I think everybody else does. And consequently, they all do it, despite the fact that most of them really don't want to do it, or maybe don't want to do it to the degree that they sort of perceive as others wanting to do it. This plays out in like fraternities. It plays out in politics. It plays out in all sorts of group dynamics. But yeah, I think that is a point of intervention to maybe work with folks and say like, yeah, you know, like I know that maybe you have a certain, you know, idea about what the group values, but if we actually kind of, you know, like talk about it and kind of, you know, like do these like individual surveys and then provide feedback, you find some interesting things. It's almost enlightening to say like, wow, you know, like I find that individuals kind of think a little bit more like me and less like the group that I actually thought, or then I actually thought. Yeah. But, you know, I get the sense from my preparation for this that, you know, just because people don't seek services doesn't mean that they don't believe that those services would be helpful, right? There's just this idea that, you know, like I maybe, you know, like there's risk to seeking these services. I don't want to risk the potential outcome that, you know, could happen if I seek these services. So it then becomes sort of like, well, you know, what can I do, right? And, you know, like the camaraderie is a whole other side of this, extremely strong and positive side of this. But still, to sort of like go back and kind of like a grounding in like the camaraderie and then utilize what is accessible, it ultimately kind of leads toward, you know, heavy social drinking.
Yeah, thanks everybody for all these really excellent questions and good discussion at the end. I feel like we might be bringing it to a close at this point because everybody has places to be and things to do. So again, thank you very much, Dr. Celio.
My pleasure.
Everybody will be getting an email for the CE credits and with Dr. Celio's email, and so you can reach out with any additional questions you might have. Jenny, you have anything to add?
Yes, I wanted to thank you very much for coming to us today and providing this as a resource to the community. We really appreciate your work with veterans and for sharing your expertise and knowledge with us today. There we go.